joining us today for the Spring Medical Seminar. A quick announcement. We are working on a third medical seminar this year that will happen. We're shooting for mid-June, but we're still trying to finalize the date. We're going to have that one at the Chicago Athletic Association, and then we'll have our fall seminar in September, tentatively for September 18th. More information will be forthcoming about that. So, this morning we have some wonderful doctors here to present for you guys. We have Dr. John Fernandez, who will be presenting first. He's a board-certified orthopedic surgeon specializing in microsurgery, hand, wrist, and elbow surgery. As most of us know, he works for Midwest Orthopedics at Rush. I'm just going to go through briefly the other two. Secondly, you have Dr. Jason Urbanek, who will present to us regarding cartilage injuries of the knee. He's with Kinsdale Orthopedics and is a board-certified orthopedic surgeon with a certificate of added qualification in sports medicine. And then finally, we will have Dr. Jeffrey Ackerman of Illinois Bone and Joint present to us regarding hip injuries. He's also a board-certified orthopedic surgeon, and he specializes in hip and knee replacements, hip preservation, and hip surgery. So as Dave stated, we have a very tight schedule today. Each doctor will get an hour. If there's time after their presentation, we'll have a brief period of questions and answers. If anyone does have a question, I would ask that you raise your hand and shout it out, and then I'll repeat it for the benefit of those who will be viewing this online later. All right, thank you guys, and I will tender the floor to Dr. John Fernandez.
Awesome, thank you. Thank you for inviting me. I've done this seminar a couple times. This is actually a pretty enjoyable seminar. We usually have good questions at the end that are pretty thoughtful. I've seen some of you in the past, hopefully under good circumstances. My talk is actually going to have to do with lateral epicondylitis. My background, very quickly, I've been in Chicago for almost 25 years. I've been practicing exclusively hand surgery. I was one of the principal founders of Midwest Orthopedics. I joined Mark a few years after Mark Cohen, after he joined the group. And my background was from Indiana Hand Center, which is just right across the border. Very heavy work comp, industrial population in terms of injuries. So a lot of replants. I actually just got fresh off of a replant night before last. So we still do a lot of this stuff. I thought lateral epicondylitis would be kind of a nice topic, and what I'm going to do is in the middle, I'm going to inject some of the concepts in general in terms of how I treat work comp a little bit differently, or some of the thought processes. Lateral epicondylitis is nice because it kind of touches on work comp and also regular people. It also will talk about some of the treatments, some of the stuff that we've been actually working on, as well as biologics. And then at the end, we can go through some questions. Having said that, one of the most famous patients that I treated for lateral epicondylitis is a guy named Brandon Carter. Who knows what Mushimoto is? It's a Japanese sport similar to what you see with lumberjacks. And so I treated him successfully for many, many years. I haven't seen him in the clinic lately, but you'll get a sense of like what some of these athletic sports and things like that can do to the arm and other parts of the body. That was a joke. So we're gonna touch on epidemiology, anatomy, the science behind it, outcomes, treatments, and then we'll dig down into the actual treatments in terms of surgery. It is one of the more commonly seen overuse syndromes. How many of you have had lateral epicondylitis? Just quick show of hands. I'm in that group, by the way. And so roughly, I would say maybe a third of us or a fourth of us. So it's pretty common. Most of us have either had it or are going to have it or know somebody who has had it. It's part of a group of disorders called enthesopathy. So it would be like plantar fasciitis, Achilles tendonitis. So when you see people coming in with these conditions, you're usually asking, do you have plantar fasciitis? Have you had problems with your Achilles or your distal biceps tendon, etc.? It was described a long, long time ago, and they got coined the term lawn tennis. It was associated with lawn tennis, and hence the name stuck in terms of tennis elbow. But in actuality, only a significant minority of tennis players get tennis elbow, and the majority of the patients that I'm seeing do not play tennis. As a matter of fact, I see more golfers that get tennis elbow than any other sport. When you do see any tennis players, it tends to be somewhat dose dependent, meaning the more that they play and the heavier or the harder they play, the more likely it is that they're going to succumb to lateral epicondylitis. Work epidemiology, we can talk about this later in terms of the specifics. It tends to be jobs that give you calluses, okay? These tend to be either very heavy jobs requiring a lot of forceful gripping, grasping, especially palm down lifting or turning. It can be also lighter jobs, but that require a lot of frequency, so a lot of repetition. So we're talking about elbow extension, flexion, or rotation across the elbow. It is not going to be keyboarding or writing or filing. It's not going to be administrative tasks. And if you send me IMEs or you propose me, you know that on the record, that's what I say and that's what I stand by. So it has to be a job that's relatively physical in terms of the risk factor. There are other risk factors, including obesity, smoking, depression. There tends to be a lot of psychological overlay. Not in terms of people who get the disease, but how do they cope with the disease, right? Because like I said, I had epicondylitis for about 6 months, and I treated myself a little bit differently than the way I might treat a patient who comes into the office because of my risk tolerance for treatment. The natural history is this: they all resolve. They all resolve, but 80–90% resolve within 2 years. So I tell patients it's like the rule of thirds in terms of baseball. 1 out of 3 get better within 6 or 9 months. 1 out of 3 take up to 2 years, and then 1 out of 3 take a little longer than 2 years. But they all get better. Lateral epicondylitis is not a permanent condition. It's not arthritis, it's not a broken bone that's deformed or malunited. It is a temporary condition, but temporary could mean 2 years. So what do you do with somebody for 2 years? I had it for 6 months. I gave up some of my hobbies, but I was still able to work, so it didn't affect me. But if I had a heavy job and I couldn't do it, am I going to just sit there for 6 months? And so that's where it becomes a little bit more complicated in the work comp realm versus outside of work comp. Only about 5 to 10% of people actually need surgery. Now it depends again on the population, because if you're talking about somebody who needs to get back to work, back to heavy work, or one of their hobbies, the incidence of surgery is going to go up. But again, you'll see it in study after study, it always resolves. And this is why it makes it so confusing as to know what the hell to do with it. Because you could say, I'm going to put a piece of blue tape on your elbow and see if that makes you better. Well, you're going to get better. The question is, did you put on the blue tape right before you got better? And then you'll say, oh yeah, blue tape makes it awesome. So that's the problem. We've tried everything, as silly as that sounds. We've tried sillier things. Injecting saline, injecting prolotherapy, acupuncture, cold laser chiro, and now PRP and surgery, right? And so in some ways, it could be a little bit of a sham, because not that it's a placebo effect, but the point is it's a confounding variable, which means that these people get better anyways. So the question is, did you really change the natural history of the course of their disease? And that's what makes it confusing. What's the anatomy? It's basically the common extensor tendon. So all of the muscles and tendons that extend the wrist, that extend the fingers, join on the lateral elbow. You can all feel that pointy part of the bone, and about the size of a thumb. We actually did a lot of original research on this about 5 years ago to define the anatomy so we could do this arthroscopically. That all came from our research lab at Rush. And we basically show the anatomy in reference to arthroscopy so we can do these with arthroscopic releases. It's a diamond-shaped piece of bone, the lateral epicondyle itself is, and the tendon is the disease, not the bone. Everybody's convinced that it's the bone because they can feel that hard bone and they can bump it and tap it, and they're convinced that it's the bone because it's hard, but it's the tendon that sits on the bone that's pathologic, not the bone itself. So here you can see some slides showing the muscle, and here I've peeled it back, and that is the tendon that's involved. It's the deep tendon that's right against the bone. And so again, when you feel it and when you touch it, it feels like bone but it's actuality, it's the tendon that's against the bone that's the problem. What's the pathophysiology? Similar to treatment, there have been multiple theories, which again tells you we really don't know, right? It's a little bit of a black box mystery still. But what we do know is that there's a lot of shear stress on the tendon. That tendon is like a guitar string strung behind you, between the elbow and the wrist itself. And that tendon is relatively avascular. It has a relatively poor blood supply. And so when you rub on a tendon that doesn't have a good blood supply, and tendon tissue and collagen doesn't tend to turn over like hair, skin, nails, bone. Those are tissues that are very metabolically active. Tendon kind of just sits there. I tell patients, you form your tendon when you're in your late teens, early 20s, and then it kind of just sits there until you get into your 30s or 40s, and the whole time you're just putting wear and tear on it. So it's like your favorite pair of shoes or your favorite purse, and you're basically putting a lot of wear and tear. Eventually, something's got to give. And because the tendon has a crappy blood supply, it basically doesn't have the ability to heal, and so you develop lateral epicondylitis. Now, there's clearly predisposition. Why did I get it? Why did somebody else get it? There's going to be genetic influences, anatomic influences, age clearly, because there's a big age predisposition. So those are the parts that we can't really measure. Those are the intangibles in terms of not knowing exactly why is somebody going to get it. And that makes it harder to predict in terms of creating a safer workplace. We're trying to avoid these and get ahead of them. The pathophysiology typically starts as what we call a micro tear. And this is a pet peeve of mine because the patients will come in with all this horrible thought process that I tore my tendon, I ruptured it, it's ripped, they saw a tear on the MRI. Well, it's a tear not visible by the human eye. It's more like a fraying on the inside of the tendon. It's something you can see with an electron microscope or with a histopathologic slide, but it's not something that you see like a bicep rupture or an Achilles rupture, which is where it's truly torn off the bone. The problem is that the healing response is relatively poor. Again, why? A lot of stress at that area and a crappy blood supply. And so depending on how good you are at healing that kind of tissue, depending on how bad the micro tear is, that's what will tell you if you're going to get stuck in a neutral position where it just continues and it lingers, or if it's going to resolve itself relatively quickly. The key word that you'll hear is angiofibroblastic hyperplasia. That is the tissue that's part of the lateral epicondylitis. It's this disorganized collagen tissue. It is non-inflammatory. So a lot of people will say, well, it's got the itis at the end of it, so it must be inflammatory. And so let's try to get rid of the inflammation by taking Motrin and things like that. And the truth is, it's not inflammatory, or I should say the majority of it is non-inflammatory. So the tendon has this beautiful white structure. It's like this beautiful white woven rope or piece of material. And when you develop epicondylitis, it becomes irregular, it becomes tan colored. It's something you can see. It's almost like a tumor in the normal healthy tendon that you can actually see. The onset, most cases, I would say a plurality, but probably 30-40% present insidiously. You just wake up with it one day. You don't attribute it to work, you don't attribute it to an injury, you don't attribute it to a sport, you just suddenly have lateral elbow pain. In some cases, it can be associated with a certain type of frequency or repetitive activity. In some cases, it can occur traumatically or all of a sudden. For me, one of my hobbies is restoring old cars, and I was taking off a rusty bolt with a breaker bar, and it suddenly broke, and so my arm suddenly jerked down. And it wasn't horrible, but I felt like a little twang, and I'm like, oh, I must have pulled my muscle. The next day, I had florid lateral epicondylitis. So that's how it can happen. It doesn't have to be, a dramatic injury, but it was definitely an injury for me. It was sudden and traumatic. The symptoms are pain, unfortunately very subjective, not a lot of objectifiable findings here, not usually a lot of swelling. Sometimes you'll see some bruising or swelling if it is traumatically mediated. Weakness is a big complaint. So patients lose a lot of their grip strength. So grabbing a tool, pushing and pulling, carrying materials can be a difficult thing. Nighttime pain is usually a bad prognosticator. That usually means it's a really bad form of lateral epicondylitis, or morning stiffness. That's another bad prognosticator. This is the way we assess grip strength. I use a jammer dynamometer. I use rapid exchange, multiple position testing, trying to validate the grip strength. And that's a good way to follow it because pain is difficult for me to follow, but grip strength is a little easier and it's a little bit more objectifiable. So I can get a sense, if they're not trying to fool me, I can get a sense if their grip strength is going up, which means that the disease is getting better. Physical examination, again, paucity of objective findings. So if they have palpable tenderness right at the epicondyle, it's very pathognomonic. There are not a lot of things that can cause pain in that specific area. But there are certain things that can happen, rarely, that you have to rule out in terms of not being the cause of that pain. So arthritic conditions, ligament injuries, nerve injuries, those can all masquerade as lateral epicondylitis. We actually think that there is a connection to the shoulder. So how many of you have had cases that started off as a shoulder problem and now all of a sudden they've got lateral epicondylitis, or vice versa? So there is a connection, maybe not completely direct, where you develop a stiffness at the level of the shoulder, and now with work or with activity, your epicondyle has to do more work in terms of the shear. And so you're putting more stress on that tendon, and over time that tendon will then start to micro tear. And so we know that. We know that based on data and research. There are different physical exam finding tests that you can do. My favorite is what's called the Gardner test, which is a palm down lifting test, where you basically try to lift something up with your palm down. Patients with lateral epicondylitis have no problems lifting 50-pound suitcase with their hand palm up. So I'm at the airport, I'm lifting a big bag, I can lift it like that. But if I try to grab my shoes off the ground, palm down, I couldn't do it without it really hurting. So that's how dramatic it can be. And again, that's how you can kind of weed out people who aren't being necessarily very honest or disingenuous, because they'll have weakness in every position. But for lateral epicondylitis, it tends to be extremely specific, palm down. Differential diagnosis, start with the neck. Make sure they don't have a pinched nerve of the neck, that they can be masquerading as pain in the lateral elbow. Radial tunnel syndrome, very common to see that. Not necessarily common in the sense that in the majority of cases, but very common to see that as a misdiagnosis. So I have patients who come in for a second, third opinion. That's one of my reputations, is to do the harder cases. And patients have 2 surgeries and are no better. They don't even have lateral epicondylitis. They have radial tunnel syndrome. And then they get better with a simple surgery there. So you have to be very careful not to follow that rabbit hole in terms of what somebody else thought or somebody else did, and not to always believe the MRI or the ultrasound. Even distal biceps tendon pathology. I've seen a couple of those where they come in with a partial biceps tear and they've been treated for lateral epicondylitis, and in reality it was their distal biceps that was the problem. Radial tunnel syndrome is probably the #1 mimicker, or it's the #1 misdiagnosis. So if you've got a tough case, they've had a surgery or 2, they're not getting better, look at radial tunnel as a possible differential. The other one is the posterolateral plica. This is a little piece of scar tissue or thickening of the tissue that's behind the elbow that causes pain with extension or a click. So if you hear mechanical symptoms, they're clicking, popping with range of motion, think of a plica. Because until you address those things, the lateral epicondylitis is irrelevant because you've got a wrong diagnosis. Diagnostic studies, x-rays. There's always debate over whether or not the x-rays are helpful. In about 1/4 of cases, you'll see calcifications, which again helps me. It's something objective. And sometimes in 1 out of 8 cases, you'll pick up other pathology. It is an important thing to do, I think, in all cases, because you want to make sure they don't have arthritis or an osteochondral problem that, again, could be mimicking as lateral epicondylitis. MRI scan is the king of looking at the tendon. It's the only way to see the tendon. The problem is that the MRI scan can be falsely positive, meaning I can get an MRI scan and everybody in this room, and probably 1 out of 4 will have an abnormal looking MRI. So you have to correlate that with the objective findings. Or after surgery, the patient will ask for an MRI. Well, for sure it's going to be abnormal. The MRI scan rarely ever normalizes. It's like a scar, you know, after you've had surgery. You're always going to see the scar, even if you're doing well. And so you have to be very careful with repeat MRIs, and you have to be very careful for why you're ordering the MRI. I'm typically ordering it as a rule out. I want to kind of confirm that there's a moderate amount of disease, which usually correlates with what we see in the operating room. But you have to be careful how you order it and who's going to read it. I never ever trust the radiologist to read it. I always demand seeing the MRI myself. The radiologist is horrible at reading MRIs. They are the worst. Orthopedic surgeons are the best. They do not know the anatomy, plus they don't have the benefit of the examination. The other thing is the quality of the MRI. Do not waste your money on the MRI in the shopping center between the dry cleaner and the Starbucks. Okay, that's not going to work. You need a 1.5 to 3T MRI, high quality, up-to-date software. Otherwise, it's like taking a 2-megapixel camera picture. I mean, what quality is that compared to a 24? That's going to make a big difference in terms of making a diagnosis or a rule out. Ultrasound is becoming a common way to diagnose it. You have to have a lot of experience doing it to do it well, because it's not something you can take a picture of. So you have to, it's very technician dependent. Whereas the MRI, I can argue with the radiologist on the reading. On the ultrasound, I cannot. The advantage of the ultrasound is it's quick, cheap, and easy. I have one in my office, and so I can pull out the ultrasound, and I can quickly tell you, confirm the diagnosis. But I can do that with physical. So to me, it's not super, super helpful. But you'll hear about it or you'll read about it. And so this is a picture of an ultrasound. I mean, what the hell are we looking at? It's just blurred lines. The ultrasound is most helpful when you actually see it in a video. Otherwise, it looks like an ink blot test. It's not going to really give you valid information. So patients will come in with copies of their ultrasound, And they'll say, you know, my chiropractor, my doctor said, you know, I've got this problem and I've got this, and it's useless. I can't tell anything from the picture of the ultrasound. What are the treatment goals? The treatment goal is to get rid of the pain. That's an obvious statement, but that is at the core of it. We don't care about the tendon because the surgery involves removing a lot of the tendon. So it's not a lack of the tendon that's going to be the problem afterwards. We just want to get rid of the pain. Because if I could magically wave a wand over your sick elbow and just get rid of your pain, you would have 100% strength, you'd be able to do everything that you could do before, and you wouldn't know that there's something wrong. So it's really pain relief that we're looking to do. Now, unfortunately, that's elusive. It's not so easy to get pain relief with lateral condylitis. So we try to get the tendon to heal as quickly as possible. And again, the majority of people do not need surgery. So what are the non-operative options? We try non-operative treatment first. My guidelines are a minimum of 6 months of non-operative treatment. I will not even consider surgery on primary unless you've had 6 months of documented, reasonably good conservative treatment. Because remember what I said, at least 1 out of 3 of us will resolve the condition even if we're sitting at home doing nothing. So at the very least, I want to see time pass before we invest in the surgery because there are risks and complications to surgery. So you'll see everything from acupuncture to Botox to laser, injections, nonsteroidals, splinting, and therapy. And this is where I talk a little bit about picking the patient. So we have a patient here who has a relatively minor injury, right? A staple, this is an upholster. And then we have patients who will have more catastrophic injuries like an amputation. And you would think that the more minor injury is the more catastrophic one. But in reality, these are 2 real patients. The one with the staple never went back to work, is kind of stuck in this quagmire of pain management, etc. And I'm not making any aspersions whether it's real or not. But it started off as a relatively minor injury. Whereas the finger amputation, not the hand amputation, but the finger amputation is back at work, quote unquote full duty. But he's 3rd generation, Northwest Indiana, working in a manufacturing plant where he loves his freaking job. That's where all his friends and family are. So there is something to be said for the psychopathology of treating these conditions. And when it's something that's very pain dependent, you have to be very careful how you're going to pick those patients. Because I'm not helping my patient if I operate on them and I don't make them better. But I also can't send everybody to a psychiatrist or assess their psychosocial life. So I use the 80-20 rule in a lot of these cases in terms of trying to determine whether or not this is a good patient. These are my 3 sons, Rocco, Enzo, and Maximo. And the one wearing the socks hat is the 80-20. He's the one that consumes all of our time, all of our effort, all of the complaints. He's 80% of our time, even though he's only 20% of the family. And it's going to be like that with the lateral condylitis patients. You have to be very, very careful who you're picking, educating those patients. I'm not saying that you don't treat them at all, but you're going to treat those patients a little bit differently because otherwise it is not going to work. Nothing is going to work. Some people will say it's motivation. I don't necessarily believe that. My dad was a steel worker working minimum wage U.S. Steel in Lorain, Ohio, and you couldn't keep the guy at home, okay? He didn't make money, and he could have stayed at home. So I don't think it's necessarily just financial motivation, but there's more subtle things that go into it. There are intangible motivations that might make you want to stay at home, especially when you're told you have a quote-unquote tear of a tendon. And so that's part of what the psychology is of treating a condition that's this painful and can be truly disabling. These are prognosticators that you can use. How long have they had the problem? Are they on strong medications like Percocet and hydrocodone? And how do they dramatize, or what's the perception of their disability? Because we're all different, right, in terms of our pain, but we're also different in terms of what we would perceive as disability. I use a pain diagram in my office that's kind of stolen from the Waddell pain diagram for the back, and I use it for the upper extremity, and I'll have patients draw it out, including their face. 8 times out of 10, I can tell you the diagnosis just from the diagram that you make. That's a true fact, because it's so classic, it's so objectifiable. And so here's a case of lateral condylitis and radial tunnel syndrome, classic pain pattern. But what do you do with that? Okay, I can't fix that. I'm not going to fix that with PRP or an arthroscopic surgery, but that patient still needs treatment of some type. But I don't want to get that patient deeper in the hole in terms of exposing them to the risks of surgery. So I might treat that patient a little bit differently. So I use what I call a SPICE treatment model. It's very common to see this in the military, which is a common subset similar to work comp, right? We have usually young, healthy people, because usually they can't join or stay in the military if they're not that way. And they basically have a certain set of rules in which they work as a team. They have certain entitlements, just like we see in the work comp population. And so how do you treat them? Start with simplicity. Don't use fancy words from an MRI scan, from the radiologist read of a tear or a quote-unquote bulging disc. There isn't a single person sitting here right now that doesn't have a few bulging discs. Does that really matter? So does that tear really matter on the MRI? It may not. But you have to tell the patient what those words mean, because they're going to see it. You're going to tell them when you get the report. You don't know what it might necessarily mean. So you want to keep it simple. You want to tell them what these things mean. What does it mean to have lateral epicondylitis? You don't want to just use labels. You want to explain it to them thoroughly. Unfortunately, it takes a lot of time to do that. The biggest thing you can do is reassure the patient. Tell them, look, I know you're having a lot of pain. I know it's hard to lift your shoes off the ground. But that's okay for this disease. That's normal for this disease, because otherwise they think they have bone cancer. So you have to reassure them that what they're going through is very normal and that they will eventually get through it. Proximity. You want to keep the patient plugged into the system, whether that's in therapy or at work preferably. So if you have some type of a reasonable work program and they don't hate everybody there or vice versa, it's a good thing to keep them plugged in. They should get up in the morning with everybody else. They should get ready for work and go to work. It's a good mental thing. When you unplug somebody from the workplace, it's no good. But at the same time, you don't want to go with a one-handed restriction and then they're told to do what other people have to do with two hands. That's not reasonable either. Immediacy. You want to get to these cases early, get an accurate diagnosis early. Unfortunately, a lot of these patients will get kind of schlepped around from one clinic to another. They'll get an MRI here, a shot there, and it's disjointed treatment. They're not told from the beginning what it could or couldn't be. You come to me, I don't need an MRI, I'll tell you right away what it is, what it isn't, and you set the expectation. Centrality. You, again, similar to proximity, you want to keep a central information source. That doesn't necessarily mean case management, but you want to have a common message with the therapist, with the patient, with the employer, and the doctor. That's very important. Again, somewhat time-consuming. Not all offices are going to be conducive to that. Expectancy. This has to go with reassurance. You want to set the expectation that, hey, look, I know in 4 weeks you're going to have pain and weakness, but that's okay. Can we do this? Can we advance you? That's a very important part of the treatment process. And for lateral epicondylitis, this is one of the most important tenets of treatment. It's not like a distal radius fracture where they return to normal fairly quickly. This is something that can go on for a long, long time. And if you don't put in those types of underpinnings to the treatment model, it'll take the path of least resistance, which is usually not good. Not good for the patient, not good for the employer, not good for anybody. It's good for the doctor, because they generate income in RVUs and business. Good for maybe the attorneys who are adjudicating the cases, but not good for the patient or the employer. So what's the treatment? You want to rest them. You know, there are some people who will say, you know, you can use it as much as you want. I don't necessarily believe in that. You want to avoid, you know, pain over about a 6 out of 10. You want to limit particularly the heavier use, gripping, just like you would a tennis racket, or palm down lifting, or the rotation. Unfortunately, a lot of the assembly jobs, a lot of the manual labor jobs, the jobs that give you calluses involve that. Stretching, super important, but less than half the people do it. And this is a very important part of treatment, what they call inertial exercises, which are taught to you. You can do that at home. You don't need to go into therapy for 6 months, 4 times a week. That is unnecessary. So I'll typically send them for 6 visits. They are taught what to do. They're given some of the equipment, like the TheraBand, which I believe in, and then they go. We check that they know what they're doing, and we check again, so that's why the 6 visits. And then once we know that they're doing it, and we believe it, and we look at the band and see if it's dirty, and if there's hair and grit on it, then we know they're doing it, right? And so we plug it into the system, and they do it on their own, essentially. Strengthening begins when the pain goes down. If there's still pain, strengthening is worthless. There are some things like iontophoresis, ultrasound, H-wave, TENS that actually can be effective, and that's part of the treatment too, but not beyond 6 weeks, okay? You apply those treatments for 6 weeks, and then in my opinion, there should be a ceiling to it. If it hasn't worked after 6 weeks, it's very unlikely to work, and as you know, it can be very expensive, not to mention it gives the patient a false sense of what the goal is. Graston, cross-fictional massage, can actually be quite helpful. Remember, it's a circulatory issue. And so doing these types of modalities can actually help quite a bit in terms of improving the circulation. Non-steroidals, they help as a pain medication, but they do not help because it's not inflammatory. So the Cochrane reviews and a couple other studies that have looked at randomized controlled trials have shown no improvement in the disease process with anti-inflammatories. Topicals actually do work because they give you good pain relief. You don't have to worry about the stomach and the kidneys. So a Flector patch or something like that. Not necessarily some compound pharmacy, ultra expensive medication. Again, you want to try that? I'm all for anything. I'm for blue tape. But after about 6 weeks, if it's really not doing anything, what's the point? Okay, so you have to be a little bit careful. Straps, splints, orthotics. There's no real difference in terms of the type of orthotic, but we do know that orthotics are helpful. So wearing a splint at night, counterforce strap during the day. Treatment with injections. This is a little bit more controversial because for a long time we were using corticosteroid injections. Steroid injections were king. And now a lot of us have actually fallen out of favor. I actually rarely use cortisone injections. I'll do it in rare cases where the patient's really, really twisting my arm and begging me to do it. I don't think it'll harm you doing 1 or 2 injections, but there is some evidence that shows that cortisone injections given over a period of time can eventually harm you. It can actually leave you with a worse outcome. And a lot of the studies show it's no better than placebo. Because if I inject you, remember that the natural history for a lot of people is that they're going to get better anyway. So then you give the credit to the injection when in reality they would have gotten better anyways. But it's simple to do, it's cheap, the medication is cheap, and the injection doesn't require a high level of skill, and so it's simple, so we'll do it. But I don't like doing it anymore because the evidence just doesn't support it. It doesn't support it in terms of long-term efficacy, and it kind of, again, gives the patient a false sense of what's going on. Local needle therapy, this is the needling that some people are talking about, not a lot of high evidence with that. PRP. A guy named Jim Calandruccio, a good friend of mine from the Hand Center, was about a year before me, said one day, I've run out of stuff to inject into the elbow. And there was a paper I saw in Europe about some guy who was injecting blood for some other condition. He's like, fuck it, I'm going to inject blood. This is where PRP came from. He was injecting autologous blood in his patients and was seeing good results. So from that, the scientists then said, well, what part of the blood is the one that's helping? Well, it's the platelet-rich plasma. I take care of the holes in the socks with Nick and Brian for their hand, elbow, and wrist. This works. We have this in the freaking locker room. Does it work on everybody? No. It works well when it's given early and when you give it in a series. Not when you give it super late and not when you give it just once. But there is science that actually shows it, and most of the science is in the lateral epicondylitis research. How do you do it? You draw out 30, 40 cc's of blood from the arm, like you're doing a lab test. You put it in the centrifuge, and out pops the platelet-rich plasma. It's like oil and vinegar. It separates the blood, gives you a little layer of platelet-rich plasma that has these rich growth factors that help to call in the workman to help do the repair of the tendon. And I truly believe in it. It's not like cortisone where you're like, well, is it a placebo or not a placebo? I truly believe in it. Here's the problem. Nobody pays for it. Work comp will pay for it, thankfully, because I do think it does help. But Blue Cross Blue Shield, commercial insurance, doesn't necessarily pay for it, and it could be expensive. You're talking about anywhere from $500 to $3,000, depending on how many injections and which office you go to. So it can be a little bit pricey to tell the patient, well, we have a 50-50 chance that the injection is going to make you better quick, because that's basically the statistic behind it. Acupuncture doesn't work. It doesn't really treat the disease. It's, again, something that can help with pain, like biofeedback, etc., but the outcomes are not good. Botox, not a lot of good evidence with that. It weakens the muscle and the tendon, which again it kind of eliminates, okay, now you don't have pain because you're not pulling on the muscle and the tendon, but you still can't work because your muscle is half paralyzed. So what good does the Botox do? It doesn't really help, so I wouldn't go into that. ESWT, the shockwave therapy, this was a big fad about 15 years ago. It's almost been basically run out of the country as basically a fad that really didn't have any scientific evidence, so it doesn't really work. And again, why were we using it? Because some people would get better. They'd come back 2 weeks after the treatment and they'd say, oh my God, I'm so much better. Well, are you better because of the shockwave, or are you better because you would have gotten better anyways? So now we go to surgery. Multiple techniques. So similar to the non-surgical treatment, you've seen everything tried. And the truth is, these are the best studies. You have 2 level 1 articles. You have one level 2 article, level of evidence. I talked about this in depositions. The rest, level 4 evidence. I mean, that's like a theory. That's like you saying, hey, I think of this about that. It doesn't really have strong scientific underpinnings. So essentially only 3 articles, and what they came out of reviewing all of these articles was that everything works equally good and equally bad. So I've gone to the least invasive. So I've done it all ways. I started open, I have to develop some of the arthroscopic treatment, and now I've gone to essentially a percutaneous treatment option. And they all show similar outcomes. So percutaneous is where you're making a very small incision, and you're basically trying to release the sick part of the tendon in a way that will then promote a healing process. And again, all the studies are going to be equivalent, comparing open to percutaneous to arthroscopic. There are some slight advantages. This is a video of me doing it. This is live surgery. Patient's totally awake, a little bit of sedation, and basically a local. There's a tourniquet, so you're not going to see a lot of blood. The patient's talking to me. We have music playing in the OR. I have an ultrasound on in my left hand, and I've got this device. It's almost like a tattoo needle that basically picks at the tendon that I can see with the ultrasound, and it sucks out the debris. And I don't think it's the sucking out that's the big thing as much as it is just insulting the tendon and doing it in a very controlled laser beam way. And so there you can see us sitting, and you can see in the background the ultrasound machine. Here's the ultrasound machine. There you can see the needle flashing in. That white thing it looks like a little mountain ridge. That's the bone, and the black thing that needle in is the tendon. And so we're basically going in and out of that tendon with this needle percutaneously. I truly believe in this, not because people pay me with whiskey and wine, but because it makes a difference. At 2 weeks, I'd say probably half of these patients almost have no pain. And so that's not placebo. That's not somebody who would have gotten better otherwise. It doesn't always work. So in about half the cases, the patient will still have pain. So look at a single, a double, or maybe even strike out. And then those are the ones that then I go to the open technique. And the open technique is basically where we're making an open incision and we're carving down onto the tendon. Remember I showed you those anatomy slides earlier. And I'm basically literally just carving it out. There's virtually no skill with this other than avoiding the stuff that you shouldn't cut. But once you get down to the tendon, a monkey can do it. I mean, it's easy. You just basically take a knife and you carve it out. It's really no different. And once you carve it out, then you basically repair the remaining tissue. And then you're praying and you're crossing your fingers that they're going to heal. The problem is that again, it's an avascular tendon. So it doesn't tend to heal quickly, it doesn't tend to heal reliably. Which brings you to the topic of one of the risk factors, smoking. I will not operate on you if you're a smoker. And I used to smoke and I still cheat a little bit. So I'm not preaching. But the nicotine in vape and in cigarettes, not so much cigars, that's mostly what I smoke now, but the nicotine just kills the small blood vessels. And that, to me, is a huge risk factor in terms of failure, and we're starting to see this in the data that's coming out. But especially if you're a revision, you're just not going to get better. So what's the point of even doing the surgery? I'd rather give you a permanent restriction than operate on you for the 3rd time. So I'll tell people, I really, in all good faith and ethically, I cannot operate on you if you're smoking. And I'll make them prove it to me the way I drug test my kids for that kind of stuff with a urine continence test to make sure that they're not smoking. And that's true, I do that with my kids. So arthroscopic, this is kind of between the percutaneous and the open. The problem with arthroscopic is it's a lot of anesthesia. You have to put the patient either supine, prone or lateral position, which isn't easy. You have to give them general anesthesia typically. There's a lot more risk if you lose the airway. And there have been a lot of anesthetic, not a lot, but there are anesthetic complications. And when those happen, it's not like an infection or something like that that you're going to recover from. It's usually a big time problem. And a lot of it has to do with positioning. So I prefer lateral decubitus. I have the arm prepped out like it's an elbow, and I'm basically injecting into the elbow, putting the probes in, setting it up. So now I can see the elbow on the screen. That's me standing at the head of the elbow. And here's a video, that's the radial head rotating. The background is the lateral epicondylar tissue. That's the common extensor tendon. And so I'm taking the elbow to range of motion, confirming that there's no other intra-articular pathology. Here I am putting a probe into the elbow. that probe is much bigger than the tip of a pencil. It looks gigantic on the video because it's a little tiny camera. But once we've gone in, I then use this thing that's like a burner, and it literally vaporizes the tissue. It basically cuts through the tendon on the inside. So that's the advantage of the arthroscopic, is that you're not filleting the arm open to get to that tissue to resect it or remove it. The disadvantage, again, being the setup, the anesthesia, etc. But again, what are the results? Very good evidence. 80 to 90% good, excellent results. Well, it's 80 to 90% good, excellent results with no treatment, right? But these are the treatments that you might have to do in those 5 or 10% of patients, especially if they can't get back to work. What are the complications? They're usually pretty minor, usually wound problems, breakdown of the wound that usually heals well. Sometimes you'll see fistulas and things like that. What do you do for failed surgery? That's the challenge, right? You want to make sure, again, that you have the correct diagnosis. Remember how we were talking about earlier, radial tunnel syndrome and some of these other conditions that can mimic lateral epicondylitis? Well, if you do revision surgery, I go big. I do what's called a denervation procedure, where I'm making a large incision along the lateral elbow that looks like a cute little tunnel incision. I'm basically taking down the nerve that goes to that bone, and I'm cutting it and burying it, like a neuroma. The idea is, I just want to get rid of your pain. And so it's very effective at doing that, because we don't really care so much about the tendon. And then I do go in there, I resect more of the tendon, I'll use a suture anchor technique. So I'm belts and suspenders. I'm doing everything so I don't have to go back in there again and again and worry that I leave something behind. So at this point, we'll take some questions. It can be about anything. It doesn't have to be about lateral epicondylitis. And I'm happy to try to help out. Yes?
You mentioned that a shoulder injury can then turn into lateral epicondylitis. Can it work the other way? Can a hand injury work its way into lateral epicondylitis?
Yeah, so the question is, can a shoulder injury turn into lateral epicondylitis, and vice versa? Can a hand or wrist injury turn into lateral epicondylitis? The hand wrist, not so much. You know, we'll get that where patients are in work hardening or they're in the strengthening phase of their therapy, let's say for a wrist fracture, and then all of a sudden they'll develop lateral epicondylitis. I wouldn't say that the therapy caused it or even aggravated it. And again, this is going to be more of a legal argument we'll have at the deposition. But I would say that they developed the symptoms while they were in therapy, but they could have equally developed the symptoms even if they weren't in therapy. Whereas with the shoulder, it's a little bit different, because with shoulder stiffness, you are changing the natural history of the body, whereas with the wrist fracture, you're not. So that's the distinction, that with the shoulder, if you develop stiffness, like a frozen shoulder, et cetera, and you're in therapy and you're doing all that stuff, you've changed the way that the elbow is working biomechanically. That's the study that I showed earlier, because you've lost external rotation. So you're putting more stress on the lateral epicondylitis. So in that case, I'm more likely to buy that argument that the shoulder indirectly led to the lateral epicondylitis. But we have to be careful, right? Because it's a slippery slope. I mean, that's how a lot of you make your living, is trying to argue those points. And you can see them on both sides. But I have to rely more on the science, right? I can't just automatically assume that just because it developed during this point of the recovery that it was related. So it has to do, you know, with what was the exact nature of the injury, what exactly was going on when it developed it. But I would say that the connection is much more scientific and it's much more direct with the shoulder than it would be with the wrist and the hand. Did that answer your question? Yes, sir.
You said that most of these cases resolve eventually on their own.
All of them. 100% of them do.
So would you be saying that there's no permanent partial disability from the lateral epicondylitis case?
Well, that's a legal question, right? Because if you let me follow them for 10 years, then yeah, they wouldn't have any disability, because eventually it burns out. The problem is we put patients at MMI not based on when they're 100% better, but we place them in MMI when they reach a functional plateau, when we can't foresee when they're going to get better, because we can't sit around for 10 years trying to adjudicate the case. So it's one of these questions that's medical, but not really medical as much as it is also legal, because 100% of these cases resolve. You don't see people over the age of 60 with lateral epicondylitis. It just doesn't happen. I mean, it happens like a unicorn. I mean, you see it, but it's very rare.
So what would the long-term sequela be if there was a problem?
None. Well, what's the long-term sequela? Yeah, what's the long-term sequela if with the lateral condylitis. Is that what you're saying? Like if they'd had surgery or if they'd had it? There is none. There is no long-term sequela of the lateral condylitis. And I know a lot of you have bought into that or believe that for one reason or another. But there is no long-term sequela from lateral condylitis. It just isn't. It's just not that kind of problem. So, but they can have pain for a long time. And that's part of the reason why we think that it is permanent. Because I'll see a patient for 2, 3, 4 years, and eventually they move or die, or I move or die, and I don't see them. And so the last time I saw them, they were in pain. But we'll see patients now at the age of 50, 60, 70, and I'll see on there, oh, you had lateral condylitis surgery. How are you feeling? Oh, I'm feeling awesome. I don't have any problems. But that patient probably didn't follow up with the doctor when they were pain-free. So we get this false sense of how poorly they're doing, when in reality they do resolve. They just do. Yes? Mm-hmm. 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 So this is a case of a truck driver who had lateral condylitis, had surgery, correct? Didn't do well. In other words, had no relief at all, and then eventually returned for treatment and had a cortisone injection, and is doing well.
Yeah, but it's a
Fresh cortisone shot. And he didn't recommend a second surgery. So, and I would tend to maybe agree with that. I mean, without looking at all the facts, right? Because if the first surgery didn't work, and we know everything that I just taught you, what's the likelihood of the second surgery working? Now, maybe the first surgery was done poorly. Maybe they didn't cut out the tissue. Maybe they didn't do the release properly. So we're assuming with a lot of our patients and clients that they've had a good surgery to begin with. And only you can kind of judge that. I mean, you can see that from reputation, because typically, if you've been in practice for a while, you're either going to have a good reputation or a bad reputation or a middle of the road one. So you'll get a sense of, is this being treated by a doctor who we know doesn't necessarily have a good track record? Then you might want to get that second opinion. Then it might be a reasonable thing to revisit the surgery. But that's one where I scrub that case. I scrub that patient in terms of turning over every stone, making sure, because I don't want to get into that second trap and have a second failed surgery. Really tough to treat that. It's depressing. PRP, can the PRP be used for the knees? Yeah, they're using platelet replacement for everything, unfortunately. They're using it for wrinkles and cancer and knee arthritis. And the truth is that there's not a lot of good evidence or data to support all of that. Stem cells, I had a question earlier from somebody before I began to talk about using stem cells for arthritis. And to me, that's major snake oil. I mean, it's a $5,000, $6,000 injection. Happy to do it for you. It's the easiest thing I can do. And I can suck the stem cells right out of your pelvis with a little needle, go home with a $5,000 check. It doesn't do anything for you. There's no science whatsoever for that, for arthritis. Arthritis, I'm talking about. So you lost the cartilage. Stem cells are not going to magically suddenly grow cartilage. Nobody has ever even come close to showing that. But yet that's what you see in the newspaper, that's what you see on the internet. It's disgusting. It's like the snake oil from, Western days. Yes, sir.
Why is nighttime pain an ominous sign?
Why is nighttime pain an ominous sign? Well, number one, most conditions will tend to give you nighttime pain, right? Because that's when you're trying to rest, and unfortunately, if you've got pain, then that becomes forefront in your mind. So you tend to focus on the pain. We don't know is the answer, but we know that typically the lateral condylitis that we have a tendency to be able to fix well is the one that's activity dependent. So it's not the one that I have pain if I'm typing or writing or driving my car. It's the one I have pain when I'm turning a wrench or if I'm doing something heavier. Whereas if I have pain all the time, picking up my Starbucks and driving the car, that would tend to imply that it's more advanced, it's more sick, which would then tell you it's going to be more difficult to treat. Yes, sir?
Is there a male versus female predominance in developing lateral condylitis?
Male versus female predominance? No. So it's equal. In jobs and in sports, there is a slight predilection towards males. But that could also be because of gender bias in terms of the job being more physical, and so it tends to bias more towards physical people, whether that's somebody who's me, my stature, or somebody who's bigger, not necessarily male versus female. But you tend to see it more in males. And again, I think that that's because there's more of a gender bias, but if you really equalize those groups, there's no difference between men and women. Yes, sir.
Can you give us a little bit of background on where this onslaught of topical treatments is coming from? Is there any regulation, self-regulation, anything we can do to free up some money for the real dentists?
Yeah, you have to legislate it. I mean, that's the only, there is no, unless it's, the FDA has very poor control over topicals, and because there's not a lot of good scientific evidence, you can basically pull out any level 4 evidence and try to support it. It's really a mess. So unless you legislate it and go right to more of the scientifically based studies. I mean, look, if I have some special medicine that I can put on topically and it'll make people feel better, I want to prove that. I'll be a gazillionaire. I won't have to operate ever again. But the point is that the reason there's no proof behind it is because it doesn't exist. It'd be pretty easy to prove. Epicondylitis is pretty rampant. It's pretty common. So if you have some special cream or salve or magnet, prove it to us. Show us a study, a randomized controlled trial, which we can literally do in a year. It doesn't exist. So everything that I showed you, including things like anti-inflammatories and even therapy to some degree, is relatively scientifically useless. Yes, sir.
Yes, for those patients that have surgery, what is the actual purpose of removing tissue?
For the patients who have surgery, what is the purpose of removing the tissue? The purpose is that that's the tissue that hurts. So it's sick, right? I tell patients, think of like a frayed rope. And when you pull on that rope, you're pulling on those frayed fibers, and that's what gives you the sensation of pain, because it's sick. It's not contiguous. So when you remove that tissue, you're no longer pulling on it. Because there are some people who remove that sick tissue, like they're cutting out a tumor, and then they repair the normal tissue. There's some people who remove the tissue, they don't repair anything, like cutting out an appendix. Why does a sick appendix hurt, right? So the epicondylitis hurts as long as there's sick tendon there that you're pulling on. So the concept of the surgery is either to release it, which is what you're doing arthroscopically or with a percutaneous, or remove it like a tumor, which is what you're doing more with the open.
And when you remove it, aren't you changing the underlying structure so that you're going to affect range of motion?
So you gotta say, if you remove it, isn't that going to have a bad effect? You would think so, but the truth is it doesn't. It doesn't affect range of motion because it's a tendon, it's not a ligament, it's not the joint. So even though it's the elbow, and we always think of elbow pain, it does not affect elbow range of motion. And it doesn't affect the stability of the elbow if it's truly lateral epicondylitis. So removing the lateral, you would think intuitively, well, the designer put it in there for a reason. But the truth is we remove it all the time and people do fine. So you don't need all of it, I should say. Yes, sir.
If you have a patient that's involved in repetitive callus type work, it's difficult for them to change their body routine. For example, with a bricklayer. Now, what's the difference with that patient, whether they've had the condition without surgery versus non-surgical? For example, if they've had the surgery and it's been removed, what's the likelihood that they're going to have a problem back?
Probably 25 or 30%. So about a fourth to a third of those patients will have a recurrence if they go back to what we would all agree is the job that gave it to them. Because you're beating up on the remaining tendon, right? So, but think of how many bricklayers are out there who don't get epicondylitis. So it's a little bit more complicated than just the job. But there's no doubt that the prognosis is a lot more guarded when you're treating a patient like that, and your goal is to return them back to that job. Number one, they might be afraid that they're going to get it again, and you certainly are afraid. And because the pain, because that physical demand is so high, it's very hard to meet that, right? I mean, I could do things with a little bit of pain, but if it's something heavy like that, like a mason, that's really difficult. That would be one of the most challenging ones. The occupations that I find most challenging for epicondylitis are welders, electricians, Masons are probably almost at the top of the list. Demolition, because they're all super heavy and they put so much wear and tear on those tendons. Yes, sir.
Is there any kind of shoulder condition that is more susceptible to injury aggravation when you have epicondylitis?
So is there any shoulder condition that is more susceptible to causing or contributing to lateral epicondylitis? No. It's just the stiffness, the loss of the external rotation. And remember that that's not a, quid pro quo kind of a situation. It's not, it's not direct. It's a risk factor, just like a lot of the other risk factors, genetics, obesity, smoking, age, etc. So loss of external rotation, whether that came from a rotator cuff or an AC resection or a dislocated elbow or dislocated shoulder, it's irrelevant. It's the loss of the external rotation that biomechanically changes the way the elbow works that predisposes you or places you at risk for developing the lateral epicondylitis. That's it. Awesome. Thank you very much.